I'm Edwin Choy. I'm a medical oncologist at Mass General Hospital. This year's ESMO abstracts on sarcomas were interesting. I think we learned a few things. Um, so I'm going to present maybe 5 or 6, maybe 7 abstracts that I thought were interesting at this meeting. One was a desmoid study where they did a retrospective look at 242 patients around the idea of the question whether being pregnant or being on oral contraceptive pills would increase your risk of bad outcome. And ultimately, they compared people who were diagnosed with desmoids soon before or after pregnancy or soon before or after starting OCPs, and actually did not find that these patients had any worse outcomes than other patients who had sporadic desmoid. And so that's sort of reassuring in that we can now tell our patients who present with pregnancy-associated desmoids that they're likely to have just as good outcomes as long as we stick with standard of care. So what is standard of care for desmoid? There was another study that surveyed about 100 patients with desmoid and did a study of what happens if we start with observation as our main initial therapy for desmoid. And they found that of the 100 patients, 60 of 90 of them were stable, 20 of 90 of them actually had improved tumor or decreased tumor size. 8 of them had complete disappearance of their desmoid, and only 2 out of 90 patients had disease progression. And so this study really supports our initial sense that when patients walk into our door with a desmoid tumor, we shouldn't jump to treat them or do some sort of aggressive surgery on them, because there's a good chance that they could be stable or decrease in size if we just observe them. And so they were just nice supportive observations with how we should practice treating desmoid tumors. More into therapeutics, there was a clinical trial using a PRC2 inhibitor called MAC683 in a cohort of patients with epithelioid sarcomas. Now, these are sarcomas that have loss of SNF5, which is a chromatin remodeling protein, which leads to overactivity of PRC2. And so by using this MAC683 inhibitor, they were able to find that it can induce some partial remissions or stable disease in patients with this tumor. And so it offers us potential to have maybe a second drug in this class for epithelioid sarcomas. There was a study looking at the combination of gemcitabine and the PD-L1 inhibitor pembrolizumab in patients with leiomyosarcoma and UPS. We know that pembrolizumab is active in UPS, and this study again showed that 2 out of 2 patients treated had a partial response. In LMS, they saw no partial responses, even with gemcitabine, and 8 out of 11 patients had stable disease, which I would attribute more to the gemcitabine than the pembrolizumab. So it supports my previous suspicion that pembrolizumab is probably not a very good drug for leiomyosarcomas, but still has activity in UPS. An interesting late-breaking result was a study looking at doxorubicin with or without trabectedin. Now, doxorubicin has been studied in many other trials with or without a second agent. The most famous one was doxorubicin with or without ifosfamide, which showed increased response rates, increased PFS, but no benefit in overall survival. Likewise, this trial again showed increase in overall response rates of 38% in the combination versus 13% only in the single agent. The PFS was 13.5 months in the combination versus only 7.3 months in the single agent. However, overall survival was not statistically different in the 2 cohorts. Again, showing us that the combination of doxorubicin and trabectedin does lead to higher response rates, but that does not in itself necessarily translate to a benefit in overall survival. And then the last study that I thought was interesting was their ongoing phase 1 trial of the CAR T cell product by Adaptimmune, targeting MAGE-A4 in patients with synovial sarcomas and myxoid liposarcomas. And here they showed that the CAR T cell therapy was relatively well tolerated. 13 out of 15 evaluable patients had evidence of response to treatment, and a few patients had a pretty significant response. So I think this continues to be a very active and exciting area of investigation for sarcoma subtypes that have common antigens, like the synovial sarcomas and myxoid liposarcomas that have MAGE-A4 or NY-ESO1 as common antigens.